I think we're ready to get started, and good morning and welcome to the Davies Use Case webinar being presented by Children's Hospital Colorado on reducing the use of unnecessary tests and treatments for bronchiolitis. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use case have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it is my pleasure to welcome our speaker from Children's Hospital Colorado, Amy Tyler. Amy, I will turn the presentation over to you, and you can begin when you're ready.
Thank you so much for having me today. I want to tell you about the work we have done at Children's Colorado on de-implementing unnecessary tests and treatments in bronchiolitis. To begin with, you may be wondering, what is de-implementation? We have known for a while that we have a failure to translate evidence into practice. 30 to 40% of patients do not get treatments of proven effectiveness. And that's the science of implementation, getting people to start doing things they should be doing. On the flip side, 20 to 25% of patients get care that's not needed or potentially harmful. And that's the science of de-implementation. How do we get providers to stop prescribing and ordering tests and treatments that are not effective and potentially harmful for patients? There is no better disease process to understand de-implementation than bronchiolitis. Bronchiolitis is a viral infection of the lower airways in children, and it's the most common reason for hospitalization in infants. More than 100,000 admissions occur annually in the United States, and that is estimated to cost $1.73 billion. We have a lot of evidence about what we should be doing and shouldn't be doing in bronchiolitis. The American Academy of Pediatrics put out a national evidence-based guideline in 2014 that recommended discontinuing unnecessary and outdated tests and treatments. These tests and treatments have unintended consequences and downstream effects. For example, chest x-rays are shown to increase the use of antibiotics because on a chest x-ray, bronchiolitis looks similar to a pneumonia. Also, we know that bronchodilators do not have a benefit for patients, but oftentimes when patients get bronchodilators, it results in prolonged length of stay and downstream use of bronchodilators. So as I already mentioned, these unnecessary diagnostic tests and treatments in bronchiolitis have consequences for patients. They stay in the hospital longer and increase healthcare costs. Unfortunately, the majority of admitted bronchiolitis patients continue to receive these tests and treatments. And the reason is that most of these tests and treatments don't have replacements. And this leaves both providers and parents left with nothing but supportive care. So we aimed at the Children's Hospital Colorado to increase our compliance with the American Academy of Pediatrics Clinical Practice Guideline by decreasing the overuse of unwarranted interventions for patients with acute viral bronchiolitis in our emergency department, our urgent cares, and our inpatient units at our freestanding children's hospitals and affiliated community hospitals. To do this, to implement the guidelines, we really had to de-implement unnecessary tests and treatments. And we started by defining our local problem. We did this by using our dashboard, which I'm going to talk about more moving forward. But using data from our dashboard, we were able to compare ourselves to how other children's hospitals across the nation do in the utilization of these tests and treatments. We compared ourselves to other FIS hospitals, which are 42 tertiary care children's hospitals, on the use of bronchodilators, steroids, antibiotics, viral tests, and chest x-rays, all of which are not recommended by the American Academy of Pediatrics Clinical Practice Guideline. The first column of this table shows the benchmarks from that paper. Benchmarks are comprised of the top hospitals taking care of 10% of the admitted patient population. The next column shows the median utilization rate for all of these resources across the same 42 children's hospitals, and the final column on the right shows where we were prior to this work. As you can see, we are already performing better than the median hospital rate, but we had a ways to go to reach the benchmarks. And even if we only made a small change in the amount of bronchodilators, chest x-rays, et cetera, that we used, we can make a big impact because we care for over 3,000 patients with bronchiolitis each year, resulting in 700 to 900 admissions. The first step for our work was to put together an improvement team. This was a 40-person multidisciplinary team that included hospitalists, ED and urgent care providers, bedside nurses, respiratory therapists, IT specialists, pharmacists, and process improvement specialists. We gathered all 40 people on our team for a half-day kickoff meeting. And during this meeting, we defined the problem using our data compared to the benchmarks, and we used process mapping and key driver diagrams and other QI tools to understand what we thought was driving utilization of unnecessary resources in bronchiolitis at our institution, including defining what the barriers and facilitators to the implementation were in our context. And then based on those barriers and facilitators and drivers of utilization, we chose interventions to overcome them. And then we split up into smaller working groups to develop and implement each of the interventions. At the end of the day, we decided on our specific aim for our project, which was to reduce the percent of admitted patients who received bronchodilators, viral testing, and chest x-rays from our baseline to less than 20%, less than 15%, and less than 20%. We wanted to do this in one bronchiolitis season. So we also narrowed our focus down to 3 unnecessary tests and treatments, including viral testing, bronchodilators, and chest x-rays. So I'm going to walk through some of the key issues we considered as barriers and facilitators and what strategies we decided to use to address each of those issues. To begin with, none of this would have been possible without our dashboard. Our dashboard was real-time data from our EHR, and it refreshed daily, and was accessible by all members of the project team, which allowed each of us to filter the data by useful filters, such as the clinical unit that we worked in, the date range for a particular intervention, a payer for a patient, which provider was caring for the patient, or other important criteria. As somebody who has done quality improvement for over a decade at our institution, I can tell you that this dashboard was a game changer for us. The first thing we thought about at our kickoff meeting was, what would we hear first from providers and the care team? And we hypothesized that that would be, but which patients do need these tests and interventions? We know that we're not striving for 0% for any of these tests and treatments. However, it's very difficult to determine which of these patients may benefit from them. So we knew we were going to have to tackle this sentiment from providers. And we did this by sharing balancing measures, such as delayed diagnoses. We shared with them that we weren't missing complicated pneumonia when our chest x-ray rates went down, for example. The reason we were able to share this real-time balancing measures was that we had this information on our dashboard in real time. We could see how often kids came back to the emergency room after discharge. We could see how often kids were transferred to the ICU. And being able to share this on a very frequent basis with our front-line staff and providers really reassured the care team that we weren't causing harm by reducing these tests and treatments. The second thing we thought about is how much of the time do we order these tests and treatments just because it's habit? And we tackled this using something called a provider pledge. We took this idea from the antimicrobial stewardship literature, the idea being that we switch our automatic or habitual thinking to a more conscious thinking process. We asked providers to sign a pledge that said, I pledge to utilize only the necessary interventions in the care of patients presenting with history and physical exam findings consistent with anything less than severe acute bronchiolitis. And if a patient needs a diagnostic test or intervention, I will have a collaborative discussion with the team members, patients, and families and practice shared decision-making. What we know from that provider pledge is that providers and the care team thought consciously about when their patients needed a test or treatment rather than automatically ordering them. The next thing that we knew would make a big difference in our institution was using our EHR as a tool to implement best practices. We did this in two ways, with order sets and with our clinical pathway. Our order sets initially before this work included options for bronchodilators. So we were making it easy to do the wrong thing. Our new order sets removed the option for bronchodilators and also in bright red text reminded our providers that tests and treatments such as viral testing, bronchodilators, and chest x-rays were not necessary in the routine care of bronchiolitis, and went on to highlight the exceptions to that for the patients that would be excluded from the clinical practice guideline. We also updated our clinical care pathway to make it easier to use and to put it in, and to align the data and recommendations within it with the American Academy of Pediatrics clinical care guideline. We made an algorithm that was a one-page view of everything that you needed to know to care for a patient with bronchiolitis, either in the emergency department or the inpatient unit. And we linked our pathway to the EHR. This made it easy and accessible during routine visits with patients. We then interviewed 15 hospitalists and 15 emergency medicine physicians and asked them how they felt about the new pathway. One quote was, if it's not at your fingertips, if it's not prompting you to look at the clinical pathway, I think a lot of providers don't have the practical time to, between patients, look it up, print it out, reference it. So we made this better by making it easily accessible during the course of care. Next, we had to make sure that the care team knew that this was not a project around resources. It was what was best for the patients, and that the patients were what we wanted to, the patients were our focus. And we did this by illustrating the treatment cascade. It's not about reducing chest x-rays necessarily, but reducing the downstream effects of those chest x-rays. And while we didn't focus on antibiotics specifically during our project, we did see that in reducing our chest x-ray rates, we reduced our antibiotic utilization significantly, which has important consequences and benefits for patients. And finally, we knew that we were going to have to give our providers and care teams skills to talk to patients about these tests and treatments and set the right expectations for families. It can be a really scary thing for families to have their child sick and unable to breathe, and they come to our children's hospital for help. We knew that we had to make it easy for parents and patients to understand our goals for care. We did this by doing education early as before the patients even arrived at Children's Hospital Colorado. This is an example of a tear-off sheet that we gave to our primary care physicians who refer to Children's Hospital Colorado so that they could give this handout around expectations for care to their patients before even referring them to the children's emergency room or inpatient unit. It explained to families what bronchiolitis was and that while we were here to help and we would make sure their child got the care they needed, medications and tests and treatments had side effects and would not help their child get better. And finally, we all think we do better than we really do. And so we had to convince the providers caring for patients at Children's that they were indeed the ones ordering these tests and treatments. And we did this using audit and feedback. And again, our dashboard was key to being able to do audit and feedback the right way. We used our dashboard EHR data to give early, frequent, and individual data to our providers around how often they were ordering tests and treatments and bronchodilators, and showed them clear comparators, so their peers in the ED or their peers in hospital medicine. How often were they ordering these tests and treatments in their patients? And what we heard from them was that I think seeing your own practice put back in front of yourself with data benchmarked to peers is one of the most powerful ways to show people how they're actually practicing, not just what they think is in their head. In the end, we showed significant reduction in our use of chest X-rays, bronchodilators, and viral tests, and this work was published in the journal Pediatrics. We reduced chest X-rays by 40%, bronchodilators by 41%, and viral testing by 22% hospital-wide in our first year. This is a table from our paper showing our pre-post analysis for all patients seen everywhere, our ED patients, and our patients who were admitted. And as you can see, we made significant reductions in all of the resources. This is our control chart showing our change in the use of bronchodilators for our admitted patients, which was our target population. On the y-axis, you can see the percent of patients who received bronchodilators, and on the x-axis is the time. There are two baseline years, the first year of intervention, and then 2 years of sustained and continued improvement. And you can also see each of the interventions that we use annotated on this graph. We saw the same reduction for chest X-rays and for viral testing, so significantly reduced all three. While we did significantly reduce the utilization of all three, we did not meet our goals, which were rather ambitious goals for the first year. As you can see, the first column here is our baseline, the second column our goals, and our results at the end of year one. And importantly, we did not see any bad outcomes or adverse effects of reducing the utilization of these resources. We saw no increase in the number of revisits, either rehospitalizations or return visits to our emergency department. We saw no difference in the number of patients who required transfer to ICU, and we saw no differences in length of stay. And importantly, as I already mentioned, though we didn't concentrate on antibiotics, our reduction in chest X-ray use resulted in a significant reduction in the portion of patients who received antibiotics. And we also know that this increased the value of our health care for these patients. Our reduction in chest X-rays over the course of the first 2 years resulted in a savings of $351,000. I'm sorry, it resulted in a change of charges from $351,000 to $180,000, and for viral tests resulted in a change of $320,000 to $191,000 a year. Some lessons learned from this project were that we really do need real-time data from our EHR to provide meaningful feedback to both providers and the care team about how we're doing and act upon those data. We know that providers are willing to change their practice if given the tools necessary. And we know that EHR interventions such as the care pathway are crucial to guiding providers away from costly and ineffective interventions. We couldn't have done this work without a multidisciplinary improvement and governance team that helped spread this project throughout our institution. And we also know that we have to involve key stakeholders, including primary care physicians, PICU physicians, et cetera, early in the process so that we can set the right expectations for the entire community. And we also know that it's important to define the focus of the population in the beginning. There was some scope creep at our institution where many of these interventions were being applied by the residents to kids who are critically ill, for example, and reminding residents that this is for the routine care of routine bronchiolitis was important. So in conclusion, we achieved large decreases in the use of tests and treatments that are known to be ineffective in the care of bronchiolitis, and we sustained these improvements over multiple seasons. We used proven quality improvement methods and EHR-based solutions to achieve our goals. And we definitely saw a change in our culture in our institution. The next steps for this will be to reconvene in October to begin planning for the next bronchiolitis season with a goal of sustaining our already achieved improvements and also continuing improvements. We will and have always reviewed our data on a monthly basis to ensure that we were not seeing changes in our balancing measures and that we were sustaining our improvement over time. And then finally, our long-term goal is to learn from the data that we have to improve care by understanding which patients continue to receive these tests and treatments. We can potentially understand when they are indicated and add to the evidence base and refine the clinical practice guidelines. Thank you for your time.
Thank you, Amy, for that great presentation. And we want to remind folks where to go find this recording and other Davies use case webinars and information on how to apply for Davies. And that information can be found at the HIMSS Davies website at hims.org/Davies. Again, hims.org/Davies. And thanks again, Amy, for that great presentation.